Hello, everyone. Welcome to Brain Functioning and Brain Injury. I'm going to go ahead and share my screen with you. Give me one moment. Okay, we're ready to begin. I'm going to start off with just some numbers and some background when we come to talking about traumatic brain injury in the United States. And we're going to talk, first of all, about the differences between sexes. On the average year, 835,000 traumatic brain injuries occurred amongst males compared to 561,000 among females. Overall, TBIs occurred about 1.5 times as often among males than females. In terms of looking at these numbers, and I want to point out something about these numbers, these go back all the way from 1995 to 2001. I don't have newer numbers, but I just want to kind of show you the background of what we were dealing with way back before we had a lot of the resources that we currently have available for traumatic brain injury. First of all, you would have 50,000 deaths, over 235,000 hospitalizations, emergency department visits, over 1 million. And then the one that's always troubling, which I'm going to make reference to a lot in this discussion, question marks. Those people receiving medical care, other medical care from another source than these sources, or more importantly, no medical care at all. Now, back again in these time periods, at least 1.4 million traumatic brain injuries occurred in the United States each year. That's a big number. This again is showing you the differences by sex. Again, the red diamonds are the male and the gray squares are female. And you see once again that in all cases, except when you get over here towards 55 to 64 and older, 75 and older, in almost all cases, male TBIs dominate over females. One of the other things I'm going to be pointing out here is take a look at the age groups. And this gives you a general trend of what we're going to be seeing in the data coming up. And in particular, note where you have the highest amount of TBIs, male and female, 0 to 4, absolutely outnumbering the others by quite a margin. And then it seems to go down. It pops back up here at 15 to 19 years old, trends downward throughout the lifespan until all of a sudden we reach 74 and 75 and higher, it spikes up again. And we're going to talk a little bit more about that, of what may be going on that influences these data. This kind of breaks down for you TBIs by cause. And what you could see here is, well, 28% of these are under the category of falls. So you have the highest amount that we know of come from falls. 20% come from motor vehicle accidents. This margin here is unknown. And this is from assaults, 11%. Again, the biggest category here is this category called other, that we just don't know where those TBIs are coming from. but we're going to talk a lot more about where TBIs do come from when we do have a head injury versus an open head injury or a closed head injury. Those factors matter in terms of the origin of these traumatic brain injuries. This is going to break down TBIs by causes. And again, when you look at the causes, the most drastic one here is right over in here, ages 0 to 4 from falls. It trends downward from 5 to 9, continues trending downward. Okay, then falls continue to go down all the way up until right around here. And then we see a spike again in falls. This is again reflecting the fact that we see a lot of persons who are elderly who have falls in a variety of settings. It could be out in the community, it could be in the home, in the shower, just about anywhere. Falls are very, very frequent. I was a clinical director at a program for a nursing facility, and this is one of the number one concerns is how we can minimize fall risk. And I even recall our head nurse was so adamant that falls can be prevented if you are careful. We called this program Humpty Dumpty. It was a two-part program that I remember. And it was a very, very vigilant sort of a program where everybody looked for fall risks, things that a person may actually bump into that you might not expect, making sure that the corridors are clear, all of those sorts of things. But you clearly see the result of falls late in life and absolutely early in life. The other ones that we could look at here are assaults that happen at a lower rate and then fall off completely for the most part after age 55. And then compare this with motor vehicle accidents where you don't see much until age 15 to 19. And then you see this effect right here of more motor vehicle accidents. And then it just tapers down over the time from there. Okay, so this gives you an idea of where some of the brain injuries are coming from. This breaks down the brain injuries by age. Once again, I want to point out, in terms of emergency department ED visits, highest number, ages 0 to 4. And then again, it comes down over the lifespan until all of a sudden we see an increase in hospital visits and emergency room visits, once again, most likely due to falls. When we look at the older population, 65 years or older, each year an average of 155,000 TBIs occurred amongst older adults. Only about half of the older adult, 53.6% who sustained TBI, were treated and released from emergency room departments, which means is that we suspect that a lot of head injuries, when they do happen, they just don't get reported one way or the other. This again is breaking down ages 0 to 14 amongst children. Again, I'm going to point out falls at 39% comprise what we know to be the highest amount of brain injuries. Approximately 11% are attributable to motor vehicle accidents. Okay, this is almost 3 times as much as we would see from a motor vehicle accident. 4% from assaults. Okay. And again, this gigantic category here called other, in which those are really where the ones that are not really known and don't get really examined closely, and it just falls under the radar. Okay, I'm going to talk about 2 types of brain injury. The first one is called an open head injury. This describes upon impact to the head from the outside force, injury is seen to the skin, skull, or brain. So when we talk about skull fractures, that's an open head injury. Two things to note is that skin injury may or may not result in a TBI. Just because you have a gash on your forehead or on your head, it doesn't necessarily mean you have a TBI. But in contrast, TBIs may or may not have a skin injury. That is, if you see a skin injury, you may have a TBI, but you could also have a TBI from the next category, which is what we call closed head injuries. Okay. And a closed head injury describes when the brain swells and has no place to expand, it becomes compressed and results in intracranial pressure. The eye nerve, which is the nerve number 3, cranial nerve number 3, is compressed. So this is one of the reasons why when they take a look at you, a doctor may shine a light in your eyes to see if your pupils dilate or not. One of the indicators of whether you've had a problem with this particular nerve. So traumatic brain injury, TBI, I'll be talking and using that term, is an outside force impacts the head hard enough to cause the brain to move within the skull, or if the forces cause the skull to break and directly hurts the brain. These are TBIs. These could come from a direct blow, like a motor vehicle accident, firearms, falls, sports accidents, such as football, frequent concussions, heading the ball in soccer. It's also a possibility that you could suffer brain injury because usually when you head the ball, you're heading it. Unfortunately, people miss and they get their frontal lobe instead of where might be another place, such as the top of the head. Okay. Physical violence. So these are just examples of where you might receive a direct blow from one of these sources, and that would cause a brain injury, or I should say a traumatic brain injury. You could also get this from rapid acceleration and deceleration. This is where you're sitting in your car, you have your seatbelt is on, but because your body stays in the one place, your head jerks forward and then jerks backwards. Okay, rapid acceleration and deceleration, because the brain does not have a seatbelt, and it is, in a sense, moving within the skull when you are accelerating and decelerating. Again, this actually results in pulling nerve fibers apart and causes brain damage via damage to the tissue involved in these nerve fibers. You could get this through motor vehicle accidents, physical violence, and this is what's commonly happening with shaken baby syndrome, which is a very, very serious disorder to have. You could get also concussions, okay? Contusions constitute a TBI, contusions being to the head. A coup and contra coup. What this is actually referring to is, again, this rapid acceleration and deceleration where the body is stationary, but the head is jerked around. And the brain is, again, hitting the front of the skull, which is the coup, and then the contra coup, which is it hits the front and then hits the back. Coup, contra coup. Okay. And of course, through penetration, anything which penetrates the brain. Now, an ABI, not to be confused with TBI, an ABI is an acquired brain injury. An acquired brain injury that's not hereditary, congenital, degenerative, or induced by birth trauma, but occurs after birth. resulting in change in neural activity. A couple of these can be described as anoxic brain injuries. The brain does not receive any oxygen. The second type is called hypoxic, which the brain receives some, but not enough oxygen. Anoxic and hypoxic. All right. I've worked with many of these particular cases. One in particular, I worked with a person who was not receiving any oxygen for a period of time. She was driving a car and it went into a canal and she went underwater and was trapped in the car and was not receiving any oxygen. So that was one of the cases of an anoxic brain injury. Very, very serious, very diffuse kind of a brain injury. It did not affect one particular area, but it was actually diffuse in the sense that it affected the entire brain for the most part. And she had pretty significant deficits, particularly in memory. Here are some sources of an acquired brain injury. TBI, right? TBI is acquired after you are born. Airway obstruction, strangulation, near drowning, again, the case that I just talked about, electric or lightning strikes, vascular disruption, heart attack, stroke, arteriovenous malformation and AVM, aneurysms, infectious diseases, intracranial tumors. I had a very close friend pass away from this, from a tumor from brain cancer. It is very sad. VD, AIDS, insect carrying diseases. I worked with a gentleman one time who was working up in northern Maine, right on the border of the Canadian area, who was working on a tree farm at the time. And he got bit by a mosquito or something and developed a really bad case of encephalopathy, which I'll talk about here in a second. Hyper and higher should be hyper and hypoglycemia. Encephalopathy, seizures, toxic exposure, illegal drug use, alcohol abuse, lead poisoning, and carbon monoxide poisoning. Sadly, I've worked on just about every one of these types of cases before. Very challenging to work on a lot of these cases. So when you think of a brain injury, the most common ones we oftentimes think about are the ones that are traumatic, the TBIs. But a lot of times, once again, there are many ways in which the brain could suffer injuries. And this is just an example of sources of TBIs and more generally, ABIs. I'm going to talk about two different kinds of measures that we use when we're looking at the level of brain injury. The first one is called the Glasgow Coma Scale. This is a scale that will be able to describe upon immediately receiving a brain injury to what degree or to what scale do we see the level of functioning. What is the level of consciousness? What is the level of loss of function and all those sorts of things? So the first one we're going to talk about is mild. This is when you have a concussion, there is a change in mental status, or a loss of consciousness is very brief for a few seconds or minutes. This is the classic case in which you say that person got their bell rung. Happens in sports, high school football. We could see this sort of a thing happen. We could see this thing happen certainly in college level football and professional football. There is the loss of consciousness, the LOC is absent, but they are, again, dazed or confused. Test scans all appear normal when they go get scanned. But here are some of the things that have been reported from even a mild brain injury. You could get headaches, fatigue, sleep disturbance, irritability, sensitivity to light and noise, balance problems, decreased concentration and attention and speed of thinking, memory problems. You could probably see nausea or vomiting. And you could also see signs of depression, anxiety, or any kind of emotional mood swing. And again, this is just from a Glasgow score of 13 to 15. And again, 13 to 15 indicates a mild concussion or a mild brain injury. At a more serious level, we have a moderate brain injury in which the Glasgow Coma Scale goes now from 9 to 12 rather than 12 to 15. It's from 9 to 12. And now, as you'll see, the more serious the brain injury, the lower the coma score. Here you do see a loss of consciousness for a few minutes to a few hours. Confusion lasts from days to weeks. Physical, cognitive, and or behavioral impairment can last for months, or they could be permanent. Persons can usually recover with immediate treatment and or successfully learn to compensate for deficits. So what are we thinking about here? This is a little bit more than just a sports injury where you have your bell rung. You definitely lose consciousness. And again, it could be for a few minutes or a few hours. So when I think of this, I think of the classic Dorothy in The Wizard of Oz. She got bonked on the head by something in the house, and she lost consciousness. And when the twister was over, everybody was around her bed, and she came out of the coma, or I should say, out of loss of consciousness. And that would be a moderate brain injury. But we don't know really how serious that brain injury could have possibly been. Might have been more serious than we were led to believe. Okay. All right. And then finally, severe. Glasgow Coma Scale of 8 or less. What we're looking at here is prolonged unconscious state or coma lasting for days, weeks, or possibly months. This is definitely more serious. And each time we see the lower the Glasgow Coma Scale, the more serious and the more concerned we become with the prognosis following a brain injury. So one of the things that I'm going to talk about now is that now that we know that a person has suffered a brain injury, they may be in a coma. And it may have been for, again, days, weeks, or months. What do we look at then and assess? And how do we assess this when we say they're coming out of the coma? For this, we're going to use a different scale called the Rancho Los Amigos scale, or what we also call the Rancho scale. This one works in which, again, the lower the response, or I should say the lower the score, the more serious the situation is and the less responsive the person is. So in this situation, a person who is a Rancho level 1 has no response. They appear to be in a deep sleep and they are unresponsive to stimuli. Clearly, nothing. They respond to nothing. The next level is called the generalized response. Here we see a reaction that happens, but it's inconsistent, and there's no purpose in the response. It's almost like a twitch or a reflex, and it's non-purposeful to stimuli in non-specific manners. Reflexes are limited and often the same, regardless of the stimuli that are presented. So this is called the generalized response. At level 3, you start seeing some more responding to stimuli that are present in the environment. Responses are specific, but inconsistent. They are directly related to the type of stimulus presented, such as turning a head towards a sound or focusing on a presented object. They may be able to follow simple commands in an inconsistent or delayed manner. So this is now what we call localized response versus generalized response. So these are the first three levels that we see people quote coming back, coming out of this level of trauma. All right. I will come back actually to the Rancho scale when we start talking about functions of the brain, because it becomes important to know when people are coming out of the brain, the coma, and people are starting to respond once again to environmental events, and they're starting to make recovery. What does that look like from the brain aspect? Okay. So these are the first three. Now I'm going to group the next three because these are the ones that become extremely problematic a lot of times when people come out of coma. Stage 4 and stage 5. Stage 4, we call that confused and agitated. At these stages, and in particular 4, there's a heightened state of activity and the person is severely confused, very disoriented and unaware of present events. Behavior is frequently quite bizarre and inappropriate to the immediate environment. Much of the time, they're unable to perform self-care for themselves. If they're not completely physically disabled, they may perform automatic motor activities such as sitting, reaching, walking as part of an agitated state, but not necessarily as a purposeful state. So you get this discharge literally of automatic motor activity. And the person is usually in these situations quite agitated. These are the situations that call for perhaps a person to be brought in for close observation for their own safety. They may need some psychotropic medication to have them be able to calm down and be able to have people to work with them. I've worked almost exclusively with this population for literally over the past almost 40 years, since about 1985. So this has really been one of the areas that are not necessarily talked about that much, but clearly can happen. After stage 4, and you work with an individual through rehabilitation, which would probably be consisting of physical therapy, occupational therapy, speech and language therapy, perhaps even rec therapy might be involved to the degree to which a rec therapist might be able to do something with a person who is still confused and agitated. Nursing would be required more than likely. Somebody who's going to provide assistance with self-care, and certainly medical involvement. If they're having a seizure disorder from a traumatic brain injury, there are certainly going to be a neurologist involved, perhaps a neuropsychiatrist. So there's a whole team of people who are usually addressing these kinds of problems at the level 4. Level 5 is basically a situation in which you see the person who's still very confused. They're inappropriate, but they're not agitated. And this is a very big key because, again, the level of agitation becomes a very big safety concern. Even at level 5, you have only a short period of time before a person who's non-agitated will become agitated again. So this is a critical time when you're working with somebody with a traumatic brain injury. The person at level 5 appears alert and responds to simple commands. More complex commands, perhaps. However, they produce responses that are non-purposeful and sometimes random. Some agitated behavior in response to external stimuli rather than internal confusion. Highly distractible at times. Difficulty learning new information. This is again where a lot of the rehab comes into play. Manage self-care with assistance. Memory is oftentimes very impaired and verbalizations are very inappropriate and the person may just wander. So in this situation, you get a person who's wandering, they're confused, they're not agitated, but they come up to you and they start saying things that are very inappropriate, very close, very personal. And you kind of step back and go, whoa, that's a little bit too much information. But they're not agitated. They can get agitated though. And I've worked with individuals who they'll be non-agitated for a while, but if they're in an environment where sound and there's constantly some sort of sound going on and it's irritating them, they will start getting agitated because they don't know necessarily how to escape and avoid to shut that stimulus off. And that's where you may get agitation. Maybe more or less extinction related rather than brain injury related. Then we get to, again, the last grouping, what I call 6, 7, and 8. This is when we start seeing the emergence of a person's repertoire coming into play. And much of the agitation is really starting to subside. The person is still confused, though. They show some goal-directed behavior, but they rely on cueing for directions. They can relearn old skills like some of the ADLs, and that's where occupational therapy and physical therapy, boy, do these become critical parts of treatment, okay? But memory problems interfere with new learning, and that's where speech and language therapy comes into play. Very important to work on these things. At stage 6, they have beginning awareness of themselves and others, that they know that there's other people out there and it's not just about them, okay? Or it may be about them in the sense that they feel like they should have special privileges over other people because they have more wherewithal from their brain injury than somebody who's at a level 4 or 5. But they begin to understand that there's other people out there, and that becomes very important. At level 6, they also might benefit from cognitive therapy, and not just any cognitive therapy, somebody who's got vast experience of working with somebody with a brain injury, because at this stage, if they're becoming aware of themselves, they also may be becoming very aware of many of the deficits that they weren't really truly in tune to before at levels 4 and 5. And those deficits can really be very depressing. It may be grief and loss from some of the things you used to be able to do that you're now realizing you just can't do it as well. Not yet, anyway. Now we come to level 7. This is automatic appropriate. This one, we see the person going through their daily routine almost automatically, but robot-like, with appropriate behavior and minimal confusion. They have shallow recall of activities, superficial awareness of, but lack of insight into some of their conditions. But they're aware of it, but they don't really have insight into how devastating and the scope of how broad the cognitive loss may be or the physical loss may be. They require minimal supervision at this point due to impaired judgment, problem solving, and planning skills. So at this stage, we're really having the person work very closely in rehabilitation. They're doing pretty darn well, but there's still something about them. It may be that you could actually try to tell a joke or use a certain type of pragmatic, verbal skill that requires something that they might understand sarcasm, for example, but they don't respond. They don't chuckle, they don't laugh. If they do, it sounds very robotic like, because everybody else starts laughing at the comment, but they don't get it, but they just join in because everybody else is laughing. That's what we're talking about at level 7. Finally, we get the person to level 8, where their behavior is purposeful, they're appropriate, they're alert and oriented, able to recall and integrate past and recent events. They can learn new activities, and they can certainly continue learning in-home and living skills. Some deficits may be still present in terms of stress tolerance, judgment, abstract reasoning, social, emotional, and intellectual capabilities. Capacities may be present. Okay. So these are things that are now coming back into play. If you start talking more abstractly, they're going to start understanding it. If you use expressions that are a little bit metaphorical, they should be able to pick up some of these things. And there's much more purposeful behavior going on. Okay, so this again is the Rancho scale 1 to 8. All right, I'm going to talk about brain structure and function now. One of the things that I want to point out, and this was pointed out to me. Well, first let's go through the brain parts here, the brain structure. Okay, this is the frontal lobe, right in the front. And by the way, if you could see here, the forehead, the person's eye, their eyebrow, and you can see the frontal lobe actually comes down just to the eye level. It's not just the forehead, but it actually comes down further. Okay. This area right here, the frontal lobe, gives way to the temporal lobe, which is along the side by the ear. Then we come to the part up here. You can't see it, but it's the parietal lobe. And we're going to talk more exclusively about the parietal lobe in a couple of minutes. Then we got this area, the occipital lobe, right over here. And then finally, the cerebellum. This is the brain stem, the pons, and the medulla. And of course, if you're looking from the top down, and here's the eyes right here in the nose, you're looking from the top down, there's a split right down the center of the brain. And you have, again, the frontal lobe and the giving way to the parietal lobe. And again, you have a left side and a right side. We're going to talk more about that when you injure the left side, what you might see versus when you injure the right side, what you might see. Okay, here's where I wanted to talk to you about the recovery. If you think about what seems to be going on, this was pointed out by a researcher that I went and saw a number of years ago. And he pointed out that a way to conceptualize recovery from a brain injury was that it seems like levels 1, 2, and 3 are your general levels of functioning, breathing, responding to stimuli. It's very primitive what those levels of recovery are at when you're at levels 1, 2, and 3. What seems to happen is that imagine that the brain, when you go into a coma, it shuts off like a computer, just shuts off like that. Okay. What seems to happen is that during recovery, it's sort of like what your computer does when it comes on board. It doesn't come immediately on board with all of the functions and the applications. It takes a while because you have to reboot it, and it takes a process to go through that. And this again is if your computer is shut off by accident, by pulling the plug out of it. It takes a period for recovery. And what happens to conceptually is that it's like this is the part of the brain that seems to start recovering at levels 1, 2, and 3. At levels 4 and 5, some of the higher parts of the brain and the motor pathways start coming into play. Okay, 4 and 5. And then finally in 6, 7, and 8, when you're starting to come on board, and now you're starting to get some of the things that you recognize on the computer rather than jargon. Oh, yeah, there's the app. Oh, there's the other app. Oh, there's my Chrome. All those things start happening. This is level 6, 7, and 8, because what seems to happen is that with a brain injury, this is the part of the area that starts recovering last. It's gaining back much of your executive functioning. That just takes time. So that's the process. It starts from the brainstem and recovers going forward from the back of the brain, going forward to the front of the brain. Um, it's an interesting way to, conceptualize the recovery because it seems to map on to what we see when we see a person's actual recovery from a neurological and from a psychological point of view. All right. So we have again the right frontal prefrontal lobe and the left prefrontal lobe. And the frontal lobe is primarily involved in executive functioning. And when we talk about executive functioning, what we're really talking about is the ability of the brain to allow a person to do many of the things that a CEO or an executive for a big corporation should be able to do, given that they're in that high of a position of a company. Look at these skills and you'll see what I mean. A person who's at the head of a company should be able to have good initiation skills, know when things should start and when things should get going. Um, they should have good problem solving and judgment skills. They should be very important, able to inhibit behavior. That is, withhold decisions until the right decision could be made rather than making a more impulsive decision that might not be a very good idea. Okay, again, it's examining all of the things that are important. Okay, inhibition of behavior. One of the things that we find out, and I'm going to kind of talk about, is that this is one of the biggest challenges, and not just to persons with brain injury. This is a challenge to human behavior, inhibiting our behavior, hanging on and not engaging in impulsive behavior. It's the ability to step back and look at a situation and say, should I respond to this or should I wait and see if something better is going to come along, which might be more important or more beneficial rather than having a knee jerk reaction? It turns out that many species, including humans and primates, we tend to make decisions that are not necessarily in our best interest because they're impulsive decisions. Now, there's a lot of reasons why that actually happens, but at the executive level, it makes sense that this is one of the reasons why companies have a board of directors. You have a CEO at the top, but the CEO should be responding to a board of directors, and stuff should go to the board of directors for review. And companies do this, they impose this formalized structure strictly because they want to make sure that they could hold the CEO accountable and hold the person at the top who makes decisions in check. It's just a good checks balance system. Impulsivity, we're going to talk about that a little bit later because this is one of the first behaviors that becomes problematic with a traumatic brain injury. Planning and anticipating important events becomes important. Pragmatics. What are pragmatics? It's not just language, it's not just communication and speaking back and forth, but it's all the things that go into communication. Gestures, science, hand gestures, raising your eyebrows, sarcastic tone of voice, many of the things that we take for granted that go into pragmatics. It's how we, it's not just communication, but it's how we come to communicate effectively with each other. Okay. Um, Self-monitoring, the ability for you to be able to monitor, am I talking too loud? Am I going too fast? Am I talking above this person's head? Am I getting my point across? Am I losing my cool? Okay, these are very important aspects of executive functioning. Motor planning, what should I do first? What should I do second? And this is just, again, the flow of physical movement and activity and being able to plan that out. Okay. Personality and emotions. One of the first things we oftentimes see is a person's personality, quote unquote. They seem different than they were before. And emotions gets tied into that in a lot of cases because we'll talk shortly about indications of depression and anxiety that happens from a brain injury. Awareness of abilities and limitations. The awareness of knowing that, yes, I can do this. I have the ability to do this behavior or to do this skill, and the ability to reflect on yourself and say, I can't do this. I have limitations. I have to make a decision here that should I do this or should I back off? Because if I try to do this, I just don't have the necessary skills. The ability to organize your life, organize events, planning, scheduling, all of those things become important in executive functioning. Attention to concentration, again, extremely important. Mental flexibility. If this doesn't work, do that. But if this doesn't work, do this. This is also executive functioning. And then finally, speaking, expressive language, right? So this is what the frontal lobe is best for, all of these different skills. The temporal lobe on the side is involved with memory, hearing, understanding language, what we call receptive language. Also, organization, the ability to organize things around you, and sequencing, being able to know this is first, second, third, fourth, fifth, okay? That you're able to follow a sequence of events. And then we come to the parietal lobe, which is essentially up in this area, right up here. Parietal lobe is involved with sense of touch, differentiation and identification of size, shapes, and colors, spatial perception, and visual perception. The occipital lobe, what should be pretty big indicator is the root of this, OCC, because this refers to sense of vision, okay? The cerebellum, this is involved with balance, coordination, and skilled motor activity, being able to have the proper gait and being able to walk in a particular trajectory. Okay, this is where a lot of the motor skills come from, is the cerebellum. The brainstem, very, very important part of the brain, involved with breathing, heart rate, arousal and consciousness, sleep and wake cycles, attention and concentration. All right, so let's see what happens across two particular domains of changes when you have a brain injury. The first one is thinking changes. The thinking changes involve problems and changes in your ability to remember things and recall things, make decisions and plan, sequencing and organization, judgment, attention and perception, communication, reading and writing skills, thought processing speed, problem-solving skills, self-perception, thought flexibility, safety awareness, and the ability to learn new skills. All of these things can clearly happen following a brain injury. And this, again, calls upon the work of rehabilitation specialists who really do tremendous work, and not just within their own areas, but it's across domains, because the strategies, when you're doing brain injury work, everybody knows what everybody's pretty much doing. It's a very cohesive kind of way of working with somebody with a brain injury. So you certainly would have somebody involved with speech, who's involved with working with memory, decision-making and planning, communication, obviously, problem-solving skills, self-perception, thought flexibility, okay? And of course, new learning. Occupational therapy would be involved also clearly in working with a lot of those same types of skills in functional sorts of way, decision-making, judgment, attention and perception, reading and writing skills. These are the things that, again, they would work on. And then also Finally, physical therapy, who would be involved in this movement and sequencing of behavior and responding through space and time. How you're able to do that, how you're able to strengthen your legs so that you're more able and you don't have you have less of a fall risk. Okay, so this is where all of these rehabilitation come into play for thinking changes. Here, what we see a lot of times is where physical therapists come into play a lot is the physical changes, muscle movement and coordination, sleep, being able to position yourself in bed properly. You may see physical changes in hearing, vision, taste, smell, and touch, more fatigue, perhaps weakness, body weakness, balance issues, speech issues, the possibility of seizures that you didn't have before, now you have them, and then problems with sexual functioning. And then we come to the behavioral changes. These are the ones that I've been working again with for nearly 40 years. I've seen all of these different things, treated every single one of these situations, never by myself, always with a team of professionals. Okay. And let me go through those. One of the first changes that you oftentimes see are changes in social skills. A person may be become very odd in their behavior. Their way of responding socially becomes changed. It may seem like they're regressing to some degree. Sometimes their behavior seems childish. The second thing you'll see are the possibility of problems with emotional control and mood swings. Very common. Third, appropriateness of behavior, problems with self-monitoring remarks, a person's ability to know what they're doing and what they're saying is appropriate, reduced self-esteem. A person may feel very bad about themselves, and mainly because they just can't do cognitively and or physically what they used to be able to do before. You may see depression, very highly likely. Depression is probably one of the number one things that we see following traumatic brain injuries or acquired ABIs in general. And I want to point out a particular kind. We're all under the understanding what depression is. We certainly, when we hear of a person who's depressed, we think of the idea that their behavior is pressed down. They have lower, less behavior. Depression is actually a metaphorical term, if you think about it, because that's what it seems to do. It seems to press down on all of your skills so that you don't feel like sleeping, you don't feel like eating, you don't feel like interacting, you don't want to be engaged in social activity. There are many ways in which depression affects us. We cry, we don't think clearly, we become absent-minded. And that's the normal way that we look at depression. But there's another way of looking at depression as well. It's what we call agitated depression. And I worked very closely with a neuropsychiatrist who was trained in England, and he was a brain injury specialist. And he used to talk quite a bit about the agitated depression, the one that looks like anxiety. It looks like it's got all the underpinnings of anxiety, but it really is more along the lines of an agitated type of depression. The person is afraid, they're confused, they have a lot of escape and avoidance behavior, a lot of aggression, a lot of agitation. So it's just the polar opposite in its presentation as what we typically see with depression. But we would treat it, interestingly enough, the agitated depression, when we did work with folks who had this problem, we treated it with very similar kinds of depression medications, not necessarily anxiety medications, not necessarily SSRIs. In fact, we went back to some of the first generation types of antidepressant medications, and oftentimes treated it better because we found that we got some side effects with some of the SSRI medication. It actually resulted in a little bit more agitation than less agitation. So that led us to believe that any of the anti-anxieties would do the same. And sure enough, if you start giving some of the individuals anxiolytics who have agitated depression, chances are they'll get worse. And they did on our units pretty regularly. Klonopin, Ativan, any of those things which would normally be used for anxiety, it actually spiked their behavior much worse. So we just switched it to a antidepressant medication, which was being used back in those days. And we were able to work very well with the behavior using antidepressant medications. Now, that said, you could still get high rates of anxiety and frustration from a TBI. You could get you could be affected by stress. It can result in denial, where you deny that you have your brain injury and you say everybody else is wrong and I'm right. Self-centeredness, very big problem with TBIs. Anger management, ability to learn better coping skills. Perhaps before your brain injury, you never really had to use coping skills. Now you need to use some of those coping skills because there are more things that frustrate you and you need to work through. Motivation is clearly affected. Irritability and agitation is oftentimes seen. And then this excessive laughing and crying that I mentioned in my previous lecture, the pseudobulbar affective disorder from the brain injury. And I have worked with one individual in particular who we had to use that medication because he was clearly affected from his TBI with this excessive laughing. But with him, it was excessive crying. And he just really couldn't hold his emotions together. If we have an injury to the right side of the brain, what might we expect in terms of behavior changes? Well, it's important to note that if you damage the right side of your brain, it's going to affect many things on the left side of your body because it's contra-represented, as we say. For example, if you have an injury to the right side of your brain, visual spatial impairments may happen and visual memory deficits may occur, but you'll also have something called left side neglect. Damage the right side, it means that you don't pick up on a lot of stimuli that are on your left side. Okay. You also have decreased possible control, motor control over your left side. You oftentimes will have a decreased awareness of deficits. You could see altered creativity and music perception. What do I mean by that? You could actually see a person who was creative and very musically oriented. Their behavior starts to not be as good. They're not as creative, perhaps, or perhaps just the opposite. Now, before they weren't able to carry a tune, and now all of a sudden they're able to sing and long and key. These are just, again, alterations in the possibility of these two aspects of creativity and music perception. A lot of times, and this is one of the things we oftentimes see, it's a loss of big picture type of thinking. People who have a right side brain injury oftentimes find themselves going down a lot of rabbit holes. Okay. I need to do this, but what about this? I have to do this, which leads them down to going off in various different directions. You have to oftentimes reel them back in and show them the big picture. Here's what we're talking about. Here's why you're here at this clinic to receive treatment. And the person is just really thinking about only one thing that's in physical therapy that they don't like. Virtually the rest of the stuff that they're doing, they enjoy doing. But again, it's the big picture problem. They're not seeing that they're actually getting better as they go through rehabilitation. So one of the big things that we have to do in rehabilitation is to make the big picture more conspicuous. A lot of graphing, a lot of figures, a lot of feedback. You're doing great. Yesterday you only did this, but now today you could do that. And this is working towards your overall goal that you have here towards your care plan. This is what you actually have to do when you're working with folks like this. Okay. Now, if you damage the left side of your brain, it's going to affect the right side of your body. You'll have decreased control over right side body movement, perhaps. But what you'll also see with the left side brain injury is difficulty in understanding language and speaking language that would be receptive and expressive language. You oftentimes see catastrophic reactions, and this is the time you start seeing a lot of symptoms of depression and anxiety. Verbal memory deficits are possibility, impaired logic, and problems with sequencing difficulty. Okay, these are the areas that you would possibly see deficits in with an injury to the left side of the brain. If you damage the left and right side, and how might we actually do this? There's several ways, because this would not necessarily have a direct localized brain injury, but this would be more diffuse. So you could get this, for example, from the one I mentioned before, near drowning. That would result in a diffuse brain injury because all of the area of the brain has a hypoxic event that's taking place. Another way, getting an electrocution might be an actual diffuse brain injury. I've worked with somebody who got hit by lightning, actually got hit by lightning twice. And then finally, you could have this from seizure disorders, where it becomes much more of a diffuse brain injury rather than necessarily a localized brain injury. It's something which affects a greater part of the brain. Here you may see reduced thinking speed, confusion, reduced attention and concentration, fatigue, and impaired cognitive skills in all areas, particularly problems with memory. This is the big problems that I see with a lot of the folks that I've worked with who've had a diffuse brain injury. I want to mention now, brain injuries. There's something called second impact syndrome. This is a risk that happens, and it can occur when a person sustains a second TBI before the symptoms of the first TBI have healed. And this can be, the second injury may occur from days to weeks following the first one. Loss of consciousness is not required in order for a second impact syndrome. And the second impact is more likely to cause brain swelling and widespread damage. This is the tremendous fear that football players actually have when they go out and play football and they go in and they have a risk of a brain injury. It's very serious. And this is one of the reasons why when a person's, has a concussion or even has any kind of blow to the head, they need to get out of the game. That is either get out of the game immediately in the immediate sense and get observation and call it a day. Maybe call it a week until you get really checked out neurologically to make sure everything is okay. But more importantly, that you don't get thrown back into the same situation where you're going to suffer what we call second impact syndrome. This is very serious. I've worked with 3 football players, one from the NFL, who had very significant cognitive impairment from multiple concussions from an injury. It's very serious. And again, be careful when you say is it just football? No, it's contact sports. I have a patient we just got that has a soccer injury, a collision on a soccer field. So these things can happen, and they're very serious when they do. All right. I am going to talk about environmental rehabilitation. I'm going to put in a word here briefly just to pre-cue you about some stuff I'm about to talk about. We oftentimes refer to brain injury rehabilitation, but we oftentimes look at the physical rehabilitation, not the environmental rehabilitation, the physical rehabilitation. This is actually working on the person's physical body. OT, PT, speech and language, cognitive therapy, all of those things work directly on with the person. Okay, medications. Those are all types of what I could call in the category of physical therapy because it's working directly on the individual's physical system, their neurological system. What I'm going to be talking about here is two kinds of environmental rehabilitation, which looks at arranging setting conditions, not inside the body, not of the body, but surrounding the person. And this helps to conceptualize and make for better treatment. Okay, the first thing is the physical setting. This is looking at the environmental stimuli that are in the environment, the sounds, the temperature of the room. Is it optimal? Does it maximize the ability for a person to respond to pre-cues and antecedents so that they're not distracted and they're not confused? And I'll go through some examples of how that could actually happen. The physical setting also involves consequent events. When the person does the things that they are supposed to do, is the environment suited to provide the person with the proper feedback and consequences? If a person really tried to do the work, are we making sure that the consequences are good for them? That fosters learning and improves motivation. Again, I'm going to go through some examples of how we arrange consequent stimuli and how we respond and provide feedback, verbal feedback to a person that maximizes the effect. Proprioceptive stimuli. Again, these are stimuli that we have when we see ourselves engage in behavior, and we can actually close our eyes and say to ourselves, I can feel my arm rotating now with my eyes closed. I don't have to see it. I could actually feel it and respond to that stimuli. Interoceptive stimuli, the stimuli that are inside the body, and then exteroceptive stimuli, everything that is outside of the person's body. Okay, these are the kinds of things that we try to look at to enhance rehabilitation. Contingency setting is also sort of important. I'm going to be talking about this. This is much more of some ABA kind applied behavior analysis application of principles. Contingency setting involves arranging consequences to make sure that the consequences of responding are reinforcing so that the person's encouraged to do those things, and then things which end up punishing the person, making mistakes, making errors, giving error feedback. Those things may actually have detrimental effects on a person's motivation. We want to make sure that the contingencies are optimal for learning. And a lot of that means not using things and making sure things which are aversive are taken away out of the environment, at least temporarily. It's very important to do that because again, we want to use the most positively approach that we can to the learning process. And we do that by understanding contextual relations between responding and environmental events. We take a lot of data. This is what we call neurobehavioral rehabilitation, contingency arrangements. Okay, but I kind of put this under the category of environmental rehabilitation because we're not really doing the same kind of hands-on rehabilitation that an OT, speech or physical therapist might actually do. Okay. So what kind of brain injury rehabilitation is out there? There's several types. There's, first of all, what we call post-acute programs. Post-acute programs are residential programs with a focus on functional living to maximize levels of independence and treat behavioral, cognitive, psychosocial problems that prevent a person from returning home or living independently. I used to run this type of a program in Colorado, in Denver. I ran the same sort of a program in Western Massachusetts. These are very good programs and very effective, but there's just not as many as we would like to see. Effective, really good post-acute programs. And we could also see a person who goes to a long-term rehabilitation placing, which involves providing stable setting, focusing on the person's quality of life in the least restrictive environment. We used to have these programs. In fact, I ran long-term residential programs. I was a part owner of residential programs in Central Florida. And we used to take a lot of people who were in post-acute settings, who were coming out of hospital settings, but they really weren't ready to live independently yet, so that they would come into the long-term care program, and we would work with them until they got their skills refined enough, and we could find a setting that suited them, where it would be a step-down program to a more independent setting. You could also have people who live at home and they go to an outpatient or day program. They just go there, 9 to 5, get their OT, PT, and speech, get all the things that they need to do, maybe see the psychiatrist once every 2 weeks or 3 weeks, or the physiatrist, who, if they're there, they check out physically how they're doing. So we could have these various kinds of options available for persons with a brain injury. Here are some of the direct factors affecting outcomes: the age of the injury, the cause, severity, location, and frequency of brain injuries. Cause meaning what was the cause? Was it an anoxic brain injury, or was it a localized response to a part of the brain? How severe was it? What was the location of the brain injury, specifically left side, right side, both sides? And then the frequency. Is this the first one or the second one? Do we have second impact possibilities or third impact? If they were in a coma, what was their Glasgow scale and what was the duration of the coma? All that stuff is going to be very, very important in terms of outcome. Latency to treatment is also very important. The sooner you get treated, the better. That's just a general rule that you really want to get checked out if you do have a coma. It also depends on the type of treatment that you're allowed to have, and these just give you an example of all the different kinds of treatment that is available for a person with a brain injury in some programs. And then what is their personal history? Do they have a mental illness, and as a function, they did something and that caused a brain injury? They were depressed and they were driving a car and they had an auto accident. Was there any alcohol or polysubstance abuse involved in the injury, or do they have a history of that? What is their social behavior like in general? How do they function in social situations before the brain injury? If they were problematic before the brain injury rarely makes them respond better. It's usually an exaggeration of their previous functioning before the brain injury. So this goes into some of the factors that we look at in terms of outcomes. Here are some indirect factors that we could also identify. I won't spend a lot of time on this. Person's level of education, their level of finances, socioeconomic level, legal entanglements, employment, family support, insurance, and funding. All of these things clearly will factor into the level of treatment that they're able to get, the level of understanding of do they grasp the nature of their injury? Are they involved with the law? if they're employed, what's their employment, and more in particular, if the injury actually happened while they were on the job, what does their workers' compensation insurance look like? Because they're going to need every nickel of that money from workers' compensation to get better. Very important. Family support, obviously. We'll talk more about that in a couple of minutes. And then finally, the insurance and funding. This is not cheap. Injuries are very expensive, depending on how extensive they are and the length of time of the injury. And insurance companies are not really equipped, I think, for dealing with brain injury. It's just my general history. I think they're very limited on the resources and funds that they have. Workers' compensation is entirely different, I could tell you. In my work that I've done, workers' compensation is a whole different animal. I enjoy working with workers' compensation folks. It's usually a collaborative arrangement in terms of what we provide for treatment and how they reimburse. And it works out very well. And for many of our patients that we worked with, they were all on workers' compensation. It was a good thing they worked with a company that had that. If they had gotten those brain injuries on their own, they would have been in serious trouble because insurance companies just generally have a difficult time covering extensive brain injuries. Right? This is just limitations to vocational reentry. I'll just go through these briefly. Limitations in social interactions and living environment and employment opportunities. Accessibility becomes a problem with folks with a brain injury. And there are limitations galore. Interpersonal relationships and sexuality, recreational and leisure activities, limitations in transportation to get to their jobs, financial and money management, being able to manage their funds, um, limits to their funds and benefits that they might actually get from their injury. Household management and legal entanglements also become very, very big challenges to somebody who's trying to get back into the work setting. Risk management and self-control. And this involves two things in particular, alcohol and substance abuse and medication compliance. Now, why do I list these things here? I just mentioned to you, I work with workers' compensation. And one of the things that we have to think about here is from a workers' compensation point of view, they want to do everything possible to get this person better, but more importantly, get them back to work. So these are the things that we look at in rehabilitation, not just social functioning and being able to do their ADLs, but to the degree to which we could actually get them restored and back on their feet and get into the work setting again, get into the workforce again. I want to mention that there's certain things that we want to make clear and be sure of in terms of environmental safety management. We always and recommend this to caregivers, conduct frequent surveys and evaluations with caregivers providing services to persons with brain injury to ensure competency. Okay. Whoever's taking care of the person, we do a lot of in-service training. We want to make sure that they know how to care for the person. And most importantly, that we know that they're competent, that they're not just sitting there listening to us, but they could perform the skills that we would hope that would manage the person best. Conduct frequent checks for all safety devices and emergency equipment. We work closely with occupational therapy to make sure that the environment is physically set up to be safe. Conduct frequent assessments of living skills to reduce risks. These are some of the things that we caution caregivers about. Sharps, electrical tools, flammables, glass, chemicals, toxins, and what we call idiosyncratic stimuli. These are just things that can actually be harmful to the person, but you wouldn't know it at face value. You wouldn't know that they would hurt themselves. What do I mean by that? Well, let's see. Let me give you an example. I had a person on my unit one time who We had all of those things controlled. Everything was out of their reach. Everything we thought was a possible dangerous, risky object that was in their immediate environment, we thought that we had gotten rid of everything. They were at a rancho level, I want to say between 4 and 5, which means that they're inappropriate, confused, and agitated. Sometimes they're not agitated, they're appropriate. This person was sort of at the stage where he was starting to get appropriate, so we started giving him back his ability to hold his ADLs, his stuff, not his sharps, not his razors, none of that stuff, but we did give him shaving cream, as well as soap and shampoo that he kept in his container. And he tried to harm himself by taking the shaving cream and putting it in his mouth and filling up his mouth and throat with shaving cream. That is an idiosyncratic stimulus. Nobody expected that. Nobody, what we do now, it's part of our protocol that we make sure that that stuff doesn't get handed out quite quickly before we assess them to make sure that they are in a state where they could actually handle such stimuli. All right. So that's, again, a safety risk. Antecedent variables. I'm going to talk about three things: the antecedents, the behavior, and the consequence. This is the ABC section of our discussion. Antecedent variables. We find that after a person has a TBI, there's a wider range of aversive stimuli that will affect their behavior. There are three ways of examining this. One, the dimensions of the stimuli, visual, auditory, tactile examples. Certain things will become aversive. Lights, bright lights, red lights, low lights where there's shadows that create shadows that make a person think they're hallucinating, loud noises, unusual sounds, um, drawers that you open and close and they're really loud and wake the person up. Um, I just think back to my hospital days. On the hospitals, we used to have these sheets that surround the bed, like privacy sheets, and the sound of pulling those sheets back, the metal on the rod, used to really get some of our patients angry. They hated that sound. Um, so those are the possibilities. The things that they feel, clothing will affect them. They don't like to have this material anymore, whereas before they were able to handle that material. So they become tactile defensive. Water, taking showers, water hitting them from a shower. Sometimes we have to actually not have the shower on, but kind of get them acclimated to being able to tolerate the shower hitting their head again, because it's something that's now aversive. Okay. Properties, the volume, how loud is the stimulus? How frequent is the stimulus? Those things become, again, very problematic. If it's a sound like a beep that happens once every 20 minutes versus a beep that happens once every 10 seconds, those are the things that might affect them. Setting and context. Again, this is some of the things that we don't have time to really get into, but the fact that you're asking a person to do something in your session might be different than the way you ask him to do something within the natural context. And it could be that there's more confusion in the natural context than in the closed setting. This is one of the reasons why we do a lot of pedestrian skills and practice skills on our grounds, walking people on sidewalks that we know are safe, and less. And if there are flat levels, then they could walk safely and not worry too much about tripping and bumping into people and stuff like that. When we take some folks out into the environment, into the more natural environment, we want to make sure they've got the general pedestrian skills down in simple environments first. Antecedent control is affected by changes in consequence. What do we mean by that? This is something that we call discrimination generalization skills. I worked with somebody who was in their home who had, this is the old fashioned type of incoming calls. When a call comes in, it rings twice versus once. So we had to teach this person that if the phone rings just once, that means pick up the telephone, it's an incoming call. But if it rings twice, ring, ring, that's actually a fax coming in. Don't pick up the phone, because if you do, the fax won't go through. And we had all kinds of problems with this guy because he would talk to his doctor on the phone, who said, I'm going to go ahead and send you the fax, which has my prescription. Take it to your pharmacy, get your prescription filled, get it done. Okay, you're running out. So the doctor hung up the phone, put the thing through, faxed it, and it was, of course, ringing twice. He'd pick it up after the second ring, and then he'd hear this blast of fax noise coming through his ears, and he kept getting this, and he'd slam the phone down, and then he didn't get the prescription. So now it would ring again, and he's getting really agitated. And now it rings once, he picks it up and he starts screaming at his doctor, when are you going to send me my fax? So you could see the repetition that goes on here. And we had to teach him, no, one ring, pick up, two rings, leave it down. So that's discrimination training that we had to go through with this person. That leads us to what we call the reduction in contextual control. A person's ability to sequence and know, first I do this, then this, then this, is oftentimes reduced. That's, again, sequencing. That's the result of an area of the brain that's involved with being able to sequence events. And again, the reduction in self-management skills, being able to know how I'm supposed to be and look and do and dress under certain circumstances. Okay, these are what we call antecedent variables. So here's some management strategies. Number one, avoid overstimulation. Setting events should be regulated, making sure that the sound is conducive, light is conducive, the temperature, crowd is reduced if the person gets overstimulated by crowds. If they get overwhelmed with requests and demands, you got to lessen it. And then finally, their schedule of activity may be just too hectic for them to carry through all of those things. Model calmness and confidence. You are always an antecedent to another person's behavior. And when you're working with somebody with TBI, you need to be calm and confident. So also be very aware of your actions, your facial expressions, and other cues that may be tips off that you're starting to get a little bit perturbed by this person's behavior. Okay, that's a very important tip. Know your limits. Structure, consistency, and predictability is very important. It keeps a person going. If they know what's going to happen in their environment, they're going to be in a better position to respond effectively. Don't be inconsistent. Use consistent routine approaches and establish daily, weekly, and monthly schedules. That helps the person remember what to do, expect what's going to happen, and makes it more predictable so that they're in better control of their environment. And then finally, choice modulation. This is really important. Making sure that they have choices that are clear, concise instructions with positive consequences for responses. In other words, what I'm saying here is that when you're asking a person to do something, make sure that there's adequate feedback for doing the activity. I have found that the more choice you give a person with a TBI, the more confused they're going to get. This is really important to understand, that if you minimize the choices, and I'm not saying restrict, there's a big difference. Restricting choice is not what I'm talking about. That is not the way to go. But you want to minimize the options that might be available, because again, a person may be losing the big picture. They may go down these rabbit holes. They may start analyzing, what about this? What about this? What about that? And it becomes so overwhelming for them that they start getting agitated and confused. So sometimes when you minimize the choices, it makes it easier. If a person, for example, I just got onto Medicare. That wasn't the easiest choice to make. That's not something that I would have a person with a TBI immediately start working on. Which supplemental plan do you want to use? Which prescription do you want to use? I was very grateful when the person who was helping me simplified my life and said, here's two. I recommend these two would be your best. You could look at them all, but here's the two based on our conversation I think you're going to really go for. Minimizing choice really does help. Okay. The behavior, the ABC, here's the response, the behavior part of it, the variables. A person's ability to do the things that they used to do may be affected. They just can't respond their repertoires like they used to be able to do. Whatever those things used to be, whether it was being able to be the host of a party or being able to manage their own money skills, being able to dance, being able to do just about anything. And when a person can't do the things that they used to like to do, we understand that there's going to be a reduction in their reinforcers in their lives, their level of satisfaction, and their quality of life is going to take a big time hit because they just can't get the joy that they used to get because they can't do it anymore. So we see grief, we see depression, we see a lot of these things. But we also see something that's also interesting. Sometimes a person may be more resistant to change. That is, whereas a person was more flexible before, said, "Oh, I'm pretty flexible. I'm easygoing. If we have to do this, I could do that." Remember, mental flexibility was one of the things we talked about in terms of behavior changes. When you hit the frontal lobe, expect to have some changes in this particular area, flexibility. And a person may become more resistant to change. They may dig their heels in more because they're not really able to get the big picture of why they need to change their behavior. Okay. Responding may become more or less sensitive to antecedents and consequences, and therefore more variable and less stable. Again, this is very, very true. So that we may have to provide more cues to a person before that we didn't have to do before their injury. Give them more prompts, give them more time to process the information. And then finally, be able to manipulate the consequences. They may not be able to handle delays. Delay may be affected and they may get really pissed off if you hold off on giving them what they're worked so hard for. So what you may need to do is change the schedule of reinforcement so they get more frequent feedback and reinforcement for simpler responses. Okay. Here's some response management strategies. Number one, always continue ongoing evaluation. It blew my mind when I was working with folks with TBI that you could go in there day after day after day and their level is, they're pretty stable. And then you go in there one day and then bam, their level of understanding, concentration skills, it just takes a big upward trend. And now they're doing things that they were not doing yesterday or the day before or the day before. I can't explain why those things happen. I wish I could. I just can't. But I evaluate skills every single day that I go in, and I encourage my staff who work with these folks to do this on a regular basis because you may find that whereas before they were a rancher level 6, now they're at a 7. Whereas but yesterday they were at a 7, all of a sudden they're at an 8. And this used to happen to me. It was rare. I could tell you it didn't happen always, but when it did, it was like it brought tears to our eyes because it brought an awareness of how delicate brain injuries and treatment can be. It's very fascinating to see this. So that's why we are always checking out their skills because if they could do stuff for themselves, let them do it for themselves. If they're safe to do it for themselves, do it that way. There's so much evidence that shows that when you allow a person to have control over their environment, it's like magic for the frontal lobe. The frontal lobe thrives on understanding and recognizing when you're controlling your environment, and when you are, depression seems to just wither away. Okay. Ongoing modulation of difficult activity levels. What we're doing here is we say break things into smaller steps. This is what we call making the environment errorless. Well, how do we do this? We want to arrange the learning environment so there's as few errors as possible. So we break activities into much smaller steps rather than long tasks. Okay. We shorten the duration of activities so that they don't get overwhelmed, makes it a little bit easier. Vary the ease and difficulties of activities. We don't want to just give them hard tasks to do. Every once in a while, throwing in easy stuff is a welcome relief. And then finally, offer breaks often, because it may be something that the person needs a break, but they can't recognize they need a break because of their self-management and self-monitoring skills. They're starting to get a little bit antsy, but they can't put their finger why they are, because they're probably doing a little bit too much work. They're putting too much effort into cognitive activity. This is one of the ones that speech therapists have to really be careful about. Okay. Speech is not easy. It's one of the most challenging things that somebody with the TBI will encounter, because whereas the other stuff, a person will probably recover pretty quickly. Cognitive stuff takes a while. And it's sometimes very frustrating, because things that you used to be able to do in a snap, now they're a challenge. And that's very difficult sometimes for people to grasp. Gradually increase and change performance criteria. Establish good compensation responses, especially good escape and avoidance responses. Being able to say, I need a break. And good attention seeking responses. I need your help. All of those things become very important in terms of teaching alternative strategies that compete with challenging ones. We want to challenge that person to so that they can come up and say, I need to talk to you right now, versus picking something up and throwing it at you, saying, I need to talk to you. It's much easier to come up and just simply say, can you spare me a minute to talk? And we need to be able to provide that kind of response. Of course, I could talk to you right now. Put what you're doing down, okay, if it is at all possible. Okay, very important. Then we come to the C, the consequent variables. Here we find that previously learned behavior reinforcer relationships are impaired. That's a fact. That will oftentimes happen. What they used to do, the behavior that they used to do, doesn't work for them anymore in these situations. Um, Rules may be altered. The effect of rules may be altered. A person may know the rules, but not actually do it. I used to work really closely with a neuropsychiatrist who was just brilliant. And she used to have a saying that a lot of times people with TBI, the hallmark of TBI is that a lot of times they could talk the talk, but they can't walk the walk, which essentially means is that they know the rules. They could tell you the rules. They can't follow the rules for one reason or another. This again becomes something that we see a lot of times with frontal lobe dysfunction. That they may know the rules, but impulsivity becomes a very big problem, and they just discount the delay of something which is of value to them and go for the immediate type of stimulus or reinforcer, which is detrimental to them. So that may be problematic. And again, substance abuse, alcohol abuse, those things are things that you can tell them over and over again, don't do that. And they'll tell you, I shouldn't do that. They may not be able to follow the rule at this point in time. Or social behaviors. The same thing holds true. Changes in the current behavior reinforcer relationships may be needed. And that's where ABA comes into strong play. And here's what we would probably do. We do something that we call cultivate the consequences. This again gets into this notion of environmental rehabilitation. We're going to cultivate the contingencies of their lives. by making sure that we start delivering important things to them that will enhance the overall outcome. First thing, reinforce initiation, not just for completing an activity. If they get up and start doing something, start delivering reinforcement, because getting up and initiation is a big problem with frontal lobe dysfunction. Quick responses to requests. That's something that you want to see rather than delays. You don't want a person to just, and again, there may be slow processing. It may be that they have to kind of think about it and think about it and think about it until they respond. That may take 45 to 50 seconds to a minute to 3 minutes, or it may be shorter. Always make sure that when you're getting faster responses, as long as they're not crazy impulsive responses that you really don't want to reinforce, but a faster reaction to an antecedent is what you're really looking for here to make it more within what we call normalized responding. Normalized in the sense that it's normalized to the contingency. That is, that's what we would expect a person to respond to in that period of time. Participation throughout the activity should be reinforced. And finally, obviously, meeting goals. We also want to teach a person, and we also want to learn to look for alternatives, compensatory responses in any form or frequency, and provide ample reinforcement for compensatory behaviors. I can't do this anymore, but I could do this, this, and this instead. This is where rehabilitation is just invaluable. I can't overstate how important rehabilitation is, and all of those people who are in rehab to contribute to teaching compensatory behaviors, PT, OT speech, ABA, rehab, voc rehab, all of those are very important, and certainly physical medicine. Maximize positive to negative statements. Sometimes we do have to give information. Sometimes we have to give feedback. And sometimes the feedback may be negative or taken the wrong way. Too much negative feedback is going to be the end of the activity if you do that. I've done this stuff enough before with and worked with rehab folks to know that this is the crux of what's going to make you an effective therapist, is this variable right here. For every time a person makes one slight mistake that you have to that you have to correct, make sure that you deliver a heck of a lot more positives for what they're doing well. So they're getting all this positive reinforcement. They're going along great. Oop, a little bit of a mistake. You have to give a little bit of feedback there. They make a response. They come back right up and do the right thing again. Give feedback, positive feedback, over and over again. We used to use the expression 8 to 1. I think that's a little bit overkill. So I'm going to give you the expression 5 to 1. 5 to 1 ratio refers to every time you make a corrective feedback response to change something that a person's doing, make sure you deliver 5 other positive responses for all the other stuff that you're doing that's really correct, as well as for correcting what they just made a mistake on. 5 to 1 ratio. Keep it reinforcing as much as possible. Okay. Remember, a lot of folks with TBI also have depression. They're probably taking antidepressant medication. And we really want to make sure that the motivation stays up at a very nice level. Consider reinforcement deliveries, make the adjustments gradually. And here's the ways: how much reinforcement do you give? The magnitude, how much do you give? The duration, how long should it be? The frequency, how many should you give? The delay, if you're going to give that reinforcer, what's the minimum amount of delay that you could do, or I should say the maximum amount you could do without the person falling apart? In other words, I'll give you an example of this. The schedule of reinforcement, how many times must they do it in order to gain access to the reinforcer? And then finally, choice and preference. Do we know that the things that they are choosing for their reinforcers are truly reinforcing? Do we have evidence of that? Did we do a preference assessment? So what does that mean with a particular person? In my verbal interactions, where I'm not giving anything to the person, I'm just verbally talking to them and giving them praise. The magnitude refers to how enthusiastic am I? If they just did something like, they were supposed to do 10 steps on physical therapy, going through the parallel bars and walking through and holding on to that, they were supposed to do 10 steps and take a break. And I find out that they just did 15. That's five more than the goal actually was expected for that day. The magnitude of the reinforcement praise is going to be more. I'm going to be much more gung ho. I'm going to show them, look at this. You're supposed to do 10, you did 15. Awesome. High five, right? Magnitude of reinforcement, the duration. I might make a big deal about it. I'm not going to make a super big deal about it. I'm not going to reinforce them for 5 minutes for the same thing. That's overkill. But I will possibly make sure that the duration is sufficient. I'm not just going to say, oh, you did 15. Good job. I'm going to make it a little bit better than that. I'm going to spice it up a little bit and say, you did 15. That's wow. That is really, really cool. Well done. 10 seconds ought to do it. The frequency. How often should I do that? Every time they meet their goal, you should be reinforcing it, right? Delay. How long is the delay that they could tolerate? You may find out that the person will start losing interest in the activity if you delay your praise longer than 15 seconds. Okay. The schedule of reinforcement. How often should you do it? Variably. You don't have to give praise every single time. Do it on every other time, every 2 or 3 times. It's what we call variable reinforcement. That's doable. And again, just keeps them going. And then again, choice and preference, make sure that they enjoy praise. That would be the start. Okay. I'm going to talk briefly about pharmacological treatment. I'm not going to get into pharmacology like I normally do. I do instead want to talk to you about um, when you are seeking pharmacology for a brain injury. This is just not your garden variety kind of problem behavior that you're treating. You're treating something very specific that's related to the brain that we know uh, based on the person's history and based on the severity of their injury. You got to go a little bit differently. By that, what I'm talking about here is you need to ensure that the medical and psychiatric professionals providing care and treatment to the person with TBI have vast experience with brain injury and more specifically with behavioral challenges, the behavioral challenges that come from a brain injury. I'm very insistent upon this. Don't be shy about asking their experience, credentials, or references. I've seen people who just get put on lots of medications for very little rhyme or reason, and then they come through our doors, and we scratch our head saying, how did you end up here? Um, it's very important to find the resources, and there are resources that you could get through your local state Brain Injury Alliance or Association. I'm sure they have references and they have a referral or a list of providers that specialize in TBI. I've been in a couple of states. I've seen almost all those states. They do have some sort of representation. Colorado, which is where I'm at right now, is one of those states that has the Brain Injury Alliance of Colorado, and you could certainly find referrals from there. Remember that medications are effective with some populations, may not be effective with the brain injury population, and may produce adverse reactions. So when in doubt, always seek a second opinion. Very, very important. That's all I'm going to say about the pharmacology end of things. I'm not going to start talking about different kinds of medications. It to suffice to say, it's complicated. It's very complicated, and it really should be addressed by somebody who really understands medications and the neural system with a brain injury. I'm also not going to get into great detail about crisis management procedures. except to give you an overview. If you are seeking that you need to get a crisis management program into place, make sure you use procedures in your crisis management procedures that are quote unquote standardized and recognized by professionals as best practice. Be aware of what we call exceptions to standard procedures. Some people with a brain injury, you cannot necessarily go in and do certain kinds of procedures because of the risk of a secondary brain injury, of a secondary other injury. A person also may be physically frail, not necessarily frail, but injured from their brain injury. They're going through PT, and you can't necessarily start going in and doing hands-on procedures with somebody who's got a problem with their arm or their whole side of their body that they've been injured. So this is what we call exceptions to standard procedures. And you should have something which is um, information about that, about what to do in these situations. You also want to avoid what we call rogue crisis management procedures, where people who come in who are caregivers or staff come in and say, well, I used to do it this way. And then another person says, well, I was taught to do this, but I learned two different procedures. Let's try this procedure instead of that one. Those are rogue procedures. They're not authorized. Nobody's approved them. Somebody could possibly get very seriously hurt. Good crisis management procedures emphasize, very important, positive strategies rather than just reactive strategies. If you're looking for the right crisis management program, make sure that they do a lot of proactive stuff. What do you do to prevent these crises? What are your verbal interactions? Because if you could keep it to a verbal, it's a lot better than it getting to a physical. What are some of those proactive strategies? Find a program that really works well to establish proactive and keeping people reinforced for not engaging in crisis-like behaviors. Finally, be sure that your crisis management training is competency-based, taught by persons with proper credentials or certificates, monitored between trainings, reevaluated, and changed as needed to meet the needs of the person served. So again, I'm not going to talk about any specific crisis management strategy, but this is a general strategy to think about if you're going to have to go in that direction. Be cautious, be careful. I also want to mention here, family support is very important for brain injury. As a general rule, families need a great deal of support both immediately and in the future. Sometimes families should seek out assistance, but fail to do so or attempt to do so too often and are met with insensitivity. This is a very delicate topic, and there are people out there who uh, in associations that I've worked with, what we call survivors. They're wonderful folks, families, professionals who have had firsthand experience in working with persons with brain injury. Invaluable to have conversations and have support from them. Utilize these support groups. Sometimes TBI groups can provide great assistance to families uh, than support with developmental disabilities, mental health, or mental illness. Sometimes just going directly to the TBI might be the way to go because, um, again, that becomes the primary focus of treatment and it becomes the problem that the treatment is directed towards. You could contact these different kinds of associations, BIAC in Colorado, BIAA, the Brain Injury Association of America, or the North American Brain Injury Society, NABIS. Finally, I'm going to go over the last slide here, teaching tips. All right, very important. You want to restore a person's maximum functioning and outcome. And to do that, you need to know what their discharge environment's going to be. Where are they going to go? Where are they going to live? What's going to be the best option for them? You want to guide them in teaching them activities. Don't necessarily do everything for the person. you want to guide them, because if you're doing everything for a person, they will eventually possibly learn to become helpless. That is, they can do it, but they feel, what's the point in doing it? I'll fail to do it. I'll let the other person do it for me. And when you have somebody who's doing everything for you, and you find that you're not doing anything for yourself, you may become depressed about that. You want to maximize teaching opportunities. Teach, teach, teach. That's the name of the game for TBI. Very important, the next two. Number four, don't take things personally. Um, that's what I would say for just about anything, whether we're talking about any mental illness, developmental disability, anything like that. We have to learn to handle things that irritate us. Okay, don't take things personally. Avoid burnout. If you have a sense of humor, I encourage you to break up your time so that you're always in contact with stuff that's at least humorous in your life, because sometimes working with TBI could be very, very sad and exhausting. So sometimes having a good sense of humor keeps you on your toes when you are off work and you need to take a break. Think and behave proactively and consistently. Very important. And again, it's better to be proactive than reactive. And then finally, structure leads to predictability. If you make your environments and situations predictable and structured, a person's going to be more successful because they'll know what the expectations are, and they'll know exactly what they need to do to be successful and to avoid failure. I am going to stop there. Stop sharing. All right, folks. That concludes our discussion of brain functioning and brain injury. I hope it was useful for you. I touched on a whole lot of different topics today. I really encourage you to look into brain injury rehabilitation and be part of a team. It's very unique, very special. And when persons have this traumatic brain injury, and in addition to that, have a developmental disability, you have to find a way to address the developmental disability over time, obviously, but you got to address the traumatic brain injury. It becomes the first order of business. Um, you'll find the field extremely rewarding and reinforcing. And the families are the most grateful people that you'll ever work with, because it's like nobody listens to them. And when they find a professional who understands brain injury, they're forever grateful. So that concludes our discussion. Thank you very much for joining us, and we'll see you the next time.